Imagine a patient walking into a clinic for an elective procedure. Something meticulously designed to enhance tissue health, regenerate nerve function, and ultimately bring pleasure.
Right.
But then 10 minutes later, they're lying completely unconscious on a stretcher because their own brain just, well, pulled the plug on their consciousness. Today, we are looking at the ultimate clinical paradox.
Yeah, it really is this fascinating collision of modern medicine and ancient biology. I mean, you have a highly calibrated regenerative technique being completely derailed by a really blunt force survival reflex. We are dealing with a profound autonomic short circuit here.
Welcome to the deep dive.
Yeah.
We are taking a massive stack of urology clinic protocols, physiological research, and medical guidelines, and really just distilling them down for you. Our mission today is very specific. What is the exact step-by-step recommended management plan for treating a patient seeking the O-shot who has a known history of recurrent vasovagal syncope, fainting during blood draws?
And the stakes here are surprisingly high for an elective procedure, because the O-shot offers incredible benefits, but it absolutely begins with a venipuncture. For a certain subset of patients, that specific trigger initiates a severe autonomic nervous system crash.
Yeah.
So our goal today is to map out how clinicians safely bridge that gap, ensuring the patient gets the care they want without their own hemodynamics just sabotaging the entire process.
Okay, let's unpack this. Before we can manage the physiological crash, we need to look at the catalyst. So the O-shot is a 30-minute non-surgical treatment aimed at female sexual health, enhancing sensation, lubrication, treating mild stress, urinary incontinence. And the entire engine of this procedure is platelet-rich plasma.
Exactly, PRP. It's the cornerstone of so many regenerative therapies right now. It relies on extracting the patient's own blood, isolating the platelets, and then utilizing the massive concentration of growth factors housed inside them. When injected back into the tissue, those growth factors stimulate angiogenesis, which is, the formation of new blood vessels, and they trigger widespread cellular repair.
So the PRP is basically a custom-made, supercharged biological repair kit. But the only way to unlock it is through a needle in the arm. There's no synthetic workaround. You have to get the raw material directly from the patient's vein.
Yeah, that venipuncture is the non-negotiable bottleneck of the procedure. The protocol requires drawing a standard volume of blood, which then goes into a centrifuge for about 30 minutes. Once the components separate, the provider extracts roughly 4 milliliters of the concentrated PRP. But you can't just inject that directly.
Because the platelets are still dormant.
Precisely. They have to be activated. So the provider mixes those 4 milliliters of PRP with 0.2 milliliters of 10% calcium chloride. Yeah, that calcium chloride acts as a chemical trigger, forcing the platelets to degranulate and release their growth factors. And once activated, the serum is immediately injected into the numbed target tissues. Usually that's 3 milliliters into the O-spot, which is the tissue between the urethra and the vaginal wall, and another 1 milliliter directly into the clitoris.
It's such an elegant procedure, but we keep coming back to that initial bottleneck. You have this treatment fundamentally designed for rejuvenation and pleasure, yet it kicks off with an invasive stimulus that triggers blood injection injury phobia, which is just wild.
It is. And what's fascinating here is the sheer mechanical force of that phobia. This isn't, it's not a psychological weakness or a low pain tolerance.
Right, it's physiological.
Very much so. When a susceptible patient encounters the trigger, whether it's a visual of the needle, the sight of their own blood, or just the physical pinch, their body initiates a paradoxical neurological cascade. It's a severe overreaction of the autonomic nervous system.
Let's dissect the anatomy of that swoon. The stimulus hits the brain, and instead of a standard sympathetic fight-or-flight response where your heart rate spikes to help you escape, the system basically throws the car into reverse at highway speeds.
Exactly. The vagus nerve suddenly dominates the autonomic response. So first, peripheral vascular resistance plummets. The blood vessels, particularly in the lower extremities, they rapidly dilate.
So the vascular container suddenly gets much larger, but the volume of blood obviously stays the same, meaning the blood just pools in the legs.
Yep. And because that blood is trapped in the lower extremities, venous return to the heart drops off a cliff. The heart senses this massive drop in returning blood volume, and instead of speeding up to compensate, the vagal surge triggers reflex bradycardia.
Which means the heart rate gets really slow.
Exactly. An abnormally slow heartbeat. So you now have a slow pump pushing against zero resistance. The inevitable result is profound hypotension. Blood pressure crashes.
And then the brain gets starved of oxygen, and it shuts off the lights. Syncope. So the sources outline a very specific cascade of warning signs before the patient actually loses consciousness. Clinicians are watching for diaphoresis, sweating, sudden pallor where the skin loses all its tone, visual disturbances like tunnel vision, tinnitus, and then, oddly, sudden yawning.
Yeah, the yawning is often the final red flag before postural tone collapses.
Wait, sudden yawning. I read that in the clinical notes, and it seems so out of place. It sounds like the body's just tired, but you're saying it's actually an early warning siren that the brain is losing oxygen.
It really is. It's a brilliant, albeit desperate, physiological reflex. When the brainstem detects the impending oxygen deficit, it triggers a massive yawn to rapidly expand the airway and force a sudden intake of oxygen.
Oh, wow.
Yeah, it's the autonomic nervous system's last-ditch effort to stave off unconsciousness. And for those of you listening, it's vital to note that this entire cascade has absolutely nothing to do with the actual volume of blood being removed.
Right, because the O shot requires a very standard small draw. It wouldn't trigger hypovolemic shock on its own. It is entirely a software glitch in the nervous system reacting to the stimulus.
Yeah.
So, knowing that this biological reflex operates like a falling line of dominoes, how do we engineer a clinical setup that prevents the first domino from even tipping?
Well, if we connect this to the bigger picture, management begins the moment the appointment is booked. The proactive prepare protocols are incredibly robust. I mean, the single most effective defense a clinician can deploy is altering the patient's hemodynamics through positioning. You never perform the blood draw with a high-risk patient sitting up in a standard phlebotomy chair. They must be supine, lying completely flat.
Because if they are horizontal, gravity is no longer a factor in cerebral perfusion.
Right, exactly. You're removing the primary mechanical advantage of the syncope. Even if the vagus nerve triggers that massive vasodilation, and even if reflex bradycardia sets in, the blood doesn't pool in the legs because it doesn't have to fight gravity to get back to the right atrium.
That makes perfect sense.
Yeah, the brain maintains adequate perfusion simply by virtue of being on the exact same horizontal plane as the heart.
It's a structural hack. And they combine that structural hack with aggressive volume loading, right? The protocol instructs the patient to drink 500 milliliters of plain water, which is about 16 ounces, exactly 15 to 30 minutes prior to the venipuncture.
The timing there is non-negotiable. Drinking that water rapidly creates an acute expansion of intravascular blood volume. It temporarily elevates their baseline blood pressure, providing a physical buffer against the impending vagal drop.
So we are basically flooding the engine with water to keep the pressure up and laying them flat so gravity can't steal the blood from their brain.
That is a great way to put it. You are artificially raising the floor so the crash doesn't hit the basement. But beyond the physical preparations, there are also pharmacological interventions. Like for extreme anticipatory anxiety, a clinician might prescribe a low-dose benzodiazepine, such as lorazepam, administered an hour prior. This blunts the initial sympathetic spike that often precedes the parasympathetic crash.
Okay. And the guidelines also heavily emphasize the use of EMLA cream or other topical anesthetics on the arm. But let me challenge that for a second. If blood injection injury phobia is largely a visual or psychological trigger, the mere sight of the needle causing the faint, how does numbing the dermal layer of the arm actually stop the brain from panicking?
It's a great question, and it really comes down to overlapping triggers. Because while the visual of the needle is a powerful catalyst, the sharp, sudden nociceptive input, the actual pain of the needle piercing the skin, is often the definitive switch that flips the autonomic reflex.
Oh, I see.
Yeah, so numbing the arm severs that physical feedback loop. The patient might see the needle, but without the corresponding sensory shock, the vagal cascade often lacks the momentum to fully initiate. You remove the pain, and you often remove the final trigger.
That is brilliant. So we have the patient supine, their intravascular volume is expanded with 500 milliliters of water, and their arm is completely numb. But this is biology, which means it's inherently unpredictable. What happens when the reflex still kicks in? We need to look at the in-the-moment interventions when those red flags, the sweating, the tunnel vision, the yawning start flashing.
This is where the patient actively fights back against their own nervous system. At the very first sign of presyncope, the patient must deploy applied muscle tension, or AMT.
Here's where it gets really interesting.
Yeah.
Because AMT is totally counterintuitive to how we normally treat medical anxiety.
Yeah.
Usually the guidance during a procedure is deep breathing, unclenching the jaw, just trying to relax, right?
Absolutely.
But the AMT protocol demands the patient aggressively cross their legs and tightly squeeze their calves, thighs, and gluteal muscles while clenching their fists. It's so counterintuitive. Why do you actually want them flexing and squeezing as hard as possible.
Because telling a patient in pre-syncope to relax is clinically dangerous. If their muscles relax, the vascular container expands further, accelerating the hypotension. AMT essentially turns the skeletal muscles into a manual pump.
Oh, wow.
Yeah, by vigorously and continuously contracting those large muscle groups, they physically compress the deep veins in the legs.
Forcing the pooled blood past the venous valves and driving it back up to the central circulation.
Precisely. It forcefully overrides the vasodilation. It rapidly restores venous return to the heart, which stabilizes cardiac output and pushes oxygenated blood back up to the brain. AMT can literally arrest a fainting episode mid-crash.
And the clinician can simultaneously introduce a sensory override known as the trigeminal shock, right? Applying a cold, wet cloth directly to the back of the neck or the forehead.
Yes. The rapid drop in skin temperature stimulates the afferent pathways of the trigeminal nerve. That intense, sudden sensory input fires straight into the brainstem and can effectively scramble the vagal signal. It acts like a hard neurological reset.
Snapping the autonomic nervous system right out of its parasympathetic dive.
Exactly.
But let's look at the worst-case scenario. Despite the supine positioning, the volume loading, the AMT, and the trigeminal shock, the patient loses consciousness anyway. The guidelines dictate a very rigid 6-step emergency response. This isn't just a checklist, is it? It's a critical sequence to prevent secondary injury.
It absolutely is. Step 1 is immediate cessation. The draw stops. The second postural tone is lost. There is this terrible lingering instinct in phlebotomy to just push through and finish it since the needle is already in. And that is a massive liability.
Right, because the patient is now unpredictable dead weight. If they seize or slump, that needle becomes a laceration hazard in the vein.
Which leads directly to step 2. Safely releasing the tourniquet, removing the needle, and immediately securing the sharps to eliminate the immediate physical danger in the workspace.
Makes sense. And step 3 requires the clinician to apply firm pressure to the puncture site with gauze. You have to achieve hemostasis while simultaneously managing an unconscious patient.
Yeah, and step 4 is paramount airway management. If the patient has slumped or their head has fallen forward, their airway could become compromised. The clinician must manually support the head and neck, ensuring unobstructed respiration.
And step 5 addresses the root cause of the syncope, cerebral hypoperfusion. If the patient is on a standard exam table, the clinician immediately elevates their legs into the Trendelenburg position.
By raising the lower extremities above the level of the heart, you are weaponizing gravity in your favor. You are dumping all that pooled venous blood directly back into the central circulation, rapidly restoring the blood pressure required to basically wake the brain up.
And step 6 is reassurance and monitoring. Coming out of a vasovagal faint is neurologically jarring. The patient will likely experience disorientation, intense fatigue, maybe a massive spike in anxiety or embarrassment. The protocol emphasizes keeping a calm environment, explaining what happened, and forcing the patient to remain lying down.
You never, ever rush the recovery. The autonomic nervous system remains incredibly unstable for several minutes post-syncope. If you allow the patient to sit up or try to walk to a recovery room too soon, they will almost certainly suffer a secondary orthostatic collapse. And that is where severe head injuries occur.
Okay. So we navigate the crisis. The patient stabilizes, their color returns, their blood pressure normalizes. The provider successfully processes the blood, and the O-shot procedure is completed. The activated PRP is injected. Now we move into the aftermath. What does the post-care protocol look like for a patient who just went through this physiological gauntlet?
Well, for the syncope recovery itself, the clinician provides a sweet drink, especially critical if the patient had been fasting, to elevate blood glucose and aid autonomic stabilization. Every single detail of the event must be rigorously documented in the chart to inform future visits. As for the O-shot itself, the recovery is remarkably brief.
Because there are no incisions, just localized injections.
Exactly. The patient can actually resume routine daily activities immediately. The primary restriction is strict pelvic rest, so avoiding sexual activity or inserting anything into the vagina for at least 24 hours. This just allows the injection sites to close and the PRP to begin its localized work. Some mild erythema, swelling, or tenderness at the injection sites is totally expected.
But the protocol highlights a massive counterintuitive rule: regarding that post-procedure tenderness.
Yes.
Providers explicitly advise against the use of ibuprofen, naproxen, or any other NSAIDs.
Yes, and this raises an important point regarding the fundamental mechanism of regenerative medicine. Why would a clinician forbid an anti-inflammatory drug when the patient is experiencing swelling and localized pain?
Well, it's because the inflammation is the entire point.
Exactly. PRP relies on inducing a controlled, acute inflammatory cascade. When those platelets degranulate, the growth factors rely on the inflammatory pathways to signal stem cells and begin the process of tissue regeneration. NSAIDs work by inhibiting the cyclooxygenase enzymes, blocking the exact prostaglandin synthesis that the PRP is trying to orchestrate.
So what does this all mean? If you take an NSAI after an O shot, you are actively suppressing the exact cellular machinery you just paid thousands of dollars to activate. I mean, you just endured a venipuncture, survived a massive vagal crash, spun your blood down, activated it, and injected it, all to spark a natural healing response. Taking an anti-inflammatory right after would be like calling the fire department to put out a campfire you just spent an hour trying to light.
That is the perfect analogy. It completely neutralizes the therapy. If the patient requires analgesia, acetaminophen is generally permitted because it acts on the central nervous system rather than inhibiting peripheral inflammation, but NSAIDs are strictly off the table.
Wow. So synthesizing everything we've covered today from these urology and phlebotomy guidelines, the ultimate management plan for an O-shot patient with a history of recurrent syncope requires an incredibly precise choreography.
It is a gauntlet, but it is entirely manageable. You alter the hemodynamics proactively by having them drink 500 milliliters of water. You neutralize gravity by placing them supine. You sever the nociceptive trigger with EMA cream. You arm the patient with applied muscle tension to fight the vasodilation. And if the crash still happens, you ruthlessly follow the 6-step abort sequence. You stop the draw, secure the airway, and elevate the legs to restore cerebral perfusion.
It is a true testament to how proactive clinical management can outmaneuver our own biology. Which leaves you with something to ponder as we close out this deep dive.
Yeah.
Consider the strange paradox of the human mind-body connection we've explored today. Our autonomic nervous system is so deeply, anciently hardwired to protect us from a perceived injury, the tiny prick of a needle, that it will literally shut down our consciousness.
It acts as a massive physiological roadblock to a regenerative procedure that is ultimately designed to heal, to regenerate, and to enhance our quality of life. It really makes you wonder how much of modern medicine is just a constant, delicate negotiation with our own evolutionary survival instincts. We want to heal using cellular science, but our bodies are still reacting like we're bleeding out on the savannah. Thank you so much for joining us on this deep dive. Keep questioning, keep learning, and we'll see you next time.